presentation is on sleeping disorders, focusing on primary insomnia. The group members are Nicole Bridges, Annie Ferris, Stacey Gaddis, and Mel Scudder. According to the National Heart, Lung, and Blood Institute, sleep disorders are the most common but overlooked treatable health issues in our society. The primary neurotransmitters involved with sleep are acetylcholine, norepinephrine, and serotonin. The process of falling asleep is regulated by neurons in the hypothalamus that shut down the arousal systems, thus allowing the brain to fall asleep. Loss of these particular nerve cells contribute greatly to insomnia. Other sections of the brain involved are the lower brainstem and the forebrain that slow down physical alertness and cognitive processes. Waking up involves activation of the arousal system from the brainstem to the forebrain. Falling asleep is a top-down flow, while waking up begins at the brainstem and travels upwards to the cerebral cortex to prepare the brain for incoming sensory information. There are two major types of sleep disorders, dysomnia and parasomnia. Dysomnia is mainly recognized by environmental factors that cause the sleep disturbances, while parasomnias are attributed with abnormal behaviors or events that disrupt sleeping patterns. There are 6 major types of dysomnia and 4 major types of parasomnia. Primary insomnia is the difficult initiating or maintaining sleep or non-restorative sleep for at least 1 month. Primary hypersomnia is excessive sleepiness for at least 1 month due to prolonged sleep episodes or daytime sleep episodes that occur almost daily. Narcolepsy is the irresistible attacks of refreshing sleep that occur daily for at least 3 months, with the presence of cataplexy, recurrent intrusions of elements of REM sleep into the transition between sleep and wake. Breathing-related sleep disorders are obstructive or central sleep apnea syndrome. Circadian rhythm sleep disorders are persistent or recurrent sleep disruptions leading to excessive sleepiness or insomnia due to a mismatch between a sleep-awake schedule required by a person's environment. Dysomnia NOS are sleep disturbances that do not fit into a specific criteria. Nightmare disorders are repeated awakenings from major sleep periods or naps with detailed recall of extended or extremely frightening dreams. Upon awakening, the person rapidly becomes oriented and alert. Sleep terror disorders are recurrent episodes of abrupt awakening from sleep, usually occurring between the first third of the major sleep episode and beginning with a panicky scream. Sleepwalking disorders are repeated episodes of rising from bed during sleep and walking about. While sleepwalking, the person has a blank stare, is relatively unresponsive, and can be awakened only with great difficulty. Parasomnia NOS are disturbances characterized by abnormal behavior or psychological events during sleep or sleep-wake transitions, but do not meet criteria for more specific parasomnia. The risk factors for general sleep disorders include family history, stress, and co-occurring illnesses. And for dysomnia, hormonal changes in women and aging. The general symptoms for sleep disorders include excessive daytime sleepiness, difficulty initiating or maintaining sleep, or abnormal movements, behaviors, and sensations occurring during sleep. The first category of insomnia includes self-induced, lifestyle, and substance use. Lifestyle examples include shift working, irregular sleep-wake schedule, poor sleep hygiene, stress, and environmental factors. Substance examples include alcohol, caffeine, hypnotics, sedatives, cocaine, amphetamines, and opiates. The second category of insomnia includes mental disorders, medical conditions, breathing disorders during sleep, and other sleep disorders. Mental disorders include depressive disorders, bipolar disorders, psychotic, anxiety, or eating disorders. Medical conditions include arthritis, heart disease, stomach or gastric ulcers, gastrointestinal disease, obesity, viral or bacterial infection, food or milk allergy, headaches, migraines, menopause, head injuries, epilepsy, Parkinson's disease, or Huntington's disease. Breathing disorders during sleep include sleep apnea, hyperventilation, respiratory insufficiency, or sleep-related asthma. Other sleep disorders include periodic limb movement disorders, restless leg syndrome, or circadian rhythm disorders. This graph shows the association of insomnia with other mental health issues. The highest correlation is with anxiety disorders and other disorders that are not within the DSM. The third category has no identifiable factors responsible for the complaints. 30 to 45% of adults complain of insomnia symptoms. However, only up to 10% of the general population is diagnosed with primary insomnia, and up to 25% of the elderly population is diagnosed with primary insomnia. Long-term insomnia can include these serious health risks. Many people who present with symptoms of insomnia wait for about 6 years before seeking treatment. As noted earlier, primary insomnia disproportionately affects the women and elderly and second and third shift workers. Here you can also see a map of self-reported sleep insufficiency in the United States. Note the high percentage of people who report sleep disturbances are in the Southeast. These gender, age, lifestyle, and cultural considerations should be taken into account when making treatment recommendations. Religious views may affect a person's willingness to try certain types of treatment options. Work hours may inhibit someone's ability to follow a standard treatment program. Remember, you are treating the client, not the insomnia. CBT therapy has a 50% success rate 24 months after completing therapy. 70 to 80% of insomnia patients achieve a therapeutic response with CBT, and about 40% achieve clinical remission. CBT is delivered in the context of 4 to 6 individual weekly therapy sessions. Factors such as insomnia severity, comorbidity, and use of hypnotic medication and education affect the outcome. CBT tends to be lengthy and costly. An alternative is group CBT, which may include small groups of 4 to 6 clients or as many as 10 to 12 for a psychoeducational treatment regimen. The smaller groups have the advantage of adding additional therapies throughout the group process, while the larger groups tend to be more instructional. Group therapy has been shown to be as effective as individual counseling. The National Institute for Health recommends CBT as the first treatment option for primary insomnia. Stimulus control therapy is the practice of behaviors that serve to strengthen the association between sleepiness and the bedroom environment, and to remove conditioned cues for arousal from the bed and bedroom. The implementation of stimulus control therapy involves strengthening the association between being in bed and sleeping. Behaviors that strengthen this association include going to bed only when sleepy, limiting activities in bed to sleeping, and constantly removing oneself from bed if awake for an extended period of time. Stimulus control is used in conjunction with sleep restriction therapy, which consists of the client keeping a 2-week sleep diary. The required amount of sleep is determined. The client is expected to go to sleep and wake on a very strict schedule. The sleep intervals are increased by 15 minutes until the optimum length of sleep is achieved. Relaxation training techniques are clinical procedures aimed at reducing somatic tension. Techniques involved include progressive muscle relaxation, imagery training, and medication. The idea is that the technique will create a state of relaxation and will relieve stress and tension which interferes with sleep. Sleep hygiene education gives examples of how to promote a lifestyle in congruence with sleep, such as the type of foods consumed, promotion of exercise, and environmental factors to include light, noise, and temperature. Medications include over-the-counter and prescriptions. Benzodiazepines are also used as sleep aids, but it is not recommended that they be used for more than 10 days due to the possibility of addiction. Medications in general are not considered for long-time use.
This concludes our presentation. To watch our video, please cut and paste this link into your browser window that you will find in the discussion board. Thank you.